Hello, everybody. This is Professor Al-Hazza. We are continuing our block series of the ophthalmology block. Today, we're going to be talking about the red eye. This is a very common entity. You'll be seeing it in whatever subspecialty you're in. It has nothing to do with being an ophthalmologist. So, if we want to define the red eye, it's a non-specific, almost colloquial term to describe an eye that appears red. It can be either due to illness or it can be due to injury. The term is usually useful and it refers to injection and prominence of the superficial blood vessels. It could be of the conjunctiva, the episclera, or the sclera. And it's usually caused by diseases or disorders that are adjacent of these adjacent structures. So if we look at this first nice picture, which I really like, here is your conjunctiva, and I'm going to be talking more about it. And you have a lot of adjacent structures, whether it's the cornea, whether it's the lids, whether it's the lashes. Here are the fornices. So, and then also you can go into your iris, your pupil. So any diseases that affect the eye will usually cause redness. So here, if you notice, this is really very diffuse, and this is important. And so if you look at it, this is really very diffuse, if you will, redness, and it seems very superficial. So this is what we would refer to as a conjunctivitis. If you look at this, it seems to be more deep. So this is what we would refer to not as a conjunctivitis, although it's a red eye. We would refer to it as an episcleritis, and I'll be talking more about that as we go along. So what's the relevance? It's a very frequent presentation to the general practitioner. Interestingly, the red eye does not come to the ophthalmologist. It actually goes to the general practitioner. And you, if you're a general practitioner or someone walked in with a red eye, whatever specialty you're in, you have to be able to differentiate between the serious vision threatening conditions and the simple benign conditions. And I'm hoping that I'm going to be able to help you differentiate between the two. So you could have it as when you're uh, seeing a red eye, there could be an immediate management. It could be just an initial assessment or in general. So your immediate management, you've got to know if this is an emergency and whether you need to refer it, or it can actually just regular treatment can be carried out effectively. Your initial management has to be, remember, always careful history. Always take a good history. If you want to become an excellent medical doctor, history is of essence. Visual acuity is also very important. And then, of course, as you see here, your simple pin light exam. And you can do that as a non-ophthalmologist. But in the general, it's usually a slit lamp examination. This is really very important, but that's usually done by us as ophthalmologists when you refer the patient to us. So here's your patient. This is the slit lamp, and then, of course, your doctor. And I explained that in details, of course, in our orientation and instrumentation lecture. So let's spend a couple of minutes just explaining what the conjunctiva is. When you look at your eye or your colleague's eye, it's all the white part. This is what we refer to as the conjunctiva, but it's really not the white part. White part you are seeing is actually the sclera, the white part. What the conjunctiva is a very thin tissue that actually sits in front of the sclera. So let's talk about it. There are three parts. We call it the bulbar conjunctiva, palpebral conjunctiva, and the fornical conjunctiva. When we say the bulbar, it's actually this one of the bulbar part of the eye. When we say the palpebral, it's actually the lid part. It's right here. And then when we say the fornical conjunctiva, it's from the word fornix. So it's here, it's the ends. And if you look at this nice photo, it really shows you, really interestingly, I talked about the bulbar, which is here in the middle. Then I talked about the palpebral, which would be right there. Remember, this is the lower lid. And then the fornices are the ones that are here. So please understand this. I don't want to go into the anatomy. That is really your task or chore. I want to mainly concentrate on the clinical part. Then you look at the stroma. The stroma of the conjunctiva, interestingly, there are no adenoid tissue. So technically, you don't get no adenoid tissue until you are 3 months and over. There you always see follicles and papillae. I'm going to be showing you some nice clinical photos of that. That's where you get your injection in chemoses. And I'm going to also be explaining to you what the limbus is. So when we say red eye, it refers to hyperemia of the superficially visible vessels of the conjunctiva. I mentioned the conjunctiva. It's the tissue, delicate tissue in front of the episclera and sclera. Episclera is also the tissue or the layer that's in front of the sclera. I like this picture very much. It just shows you, here is your conjunctiva, and look at all the different, if you will, parts that are adjacent to it. So you have your cornea, you have your lids, and you have your fornices, and of course your pupil. So when we say red eye, it's caused by disorders of these structures themselves, or it could be of the conjunctiva or of the adjacent structures like the eyelids, the cornea, the iris, and of course the ciliary body. And we talked about the ciliary body when we were talking about the visual impairment and glaucoma. The ciliary body is the part that produces the aqueous humor. All right, so let's move on. So many conditions lead to a red eye. It can be serious or not serious. It can be painful or painless. This is where your history, good history taking kicks in. So a detailed examination is required. That's after you take a good history. And it is rare for a painless red eye to require an urgent same-day ophthalmological assessment. So when I teach you this, I'm assuming you are not going to be ophthalmologists. These patients are going to show up in your clinic, hopefully when you graduate in a couple of years' time, and you're going to be able to differentiate the serious from non-serious. All right. So what's our differential diagnosis of the red eye? Remember, we said there are many adjacent structures. So if it's the conjunctival, this is your differential diagnosis. If it's anything within the lids, remember we said the lid is very close to the conjunctiva, will cause a red eye. And then any corneal diseases also will cause a red eye. So in conjunctival, a blepharoconjunctivitis, when we say blepharo, it means bleph lid. So you can have a conjunctival red eye, conjunctival causes, which would be because of the lid, bacteria that comes in, viral, allergic, very important. I'm going to be showing you some nice one. Any toxic or chemical reactions that can happen in the eye. Dry eyes, interestingly, will cause a red eye. Be aware of that. And then we're going to be talking about pinguiculi and pterygium. Lid diseases, the chalazion and stye. I'm going to be talking about that when we talk about the lids. This will be the 4th lecture. And then, of course, your corneal diseases, whether it's an abrasion or ulcer, which we're going to be also covering. So your differential diagnosis of the red eye, it could be an abnormal lid function, foreign body, dacryoadenitis, dacryocystitis, a masquerading syndrome, anything that's covered by the red eye. Masquerading means something that is actually masquerading, covering up. Your carotid and dural fistulas, acute angle glaucoma, we talked about that. Anterior uveitis, we'll be covering that. You don't have to worry about it. In your 5th year, episcleritis and scleritis, and then of course your subconjunctival hemorrhage, and then any infectious causes. The reason I've actually highlighted these three with yellow, these you have to refer to the ophthalmologist on the same day. So look at this. This is your eye, and it just shows you why you can get a red eye. Simply, you have your lids, you have your cornea, you have your pupil, you have your glands, all this, your sclera, your iris, your limbus. We're going to be talking about that later. So all these can cause a red eye. So you ask yourself, is it a conjunctivitis? Take a good history. A good history is really important. Is there itching, exposure to another person with a red eye, what could be contagious? Upper respiratory tract infection. If you have any influenza or a common cold, again, this can cause a red eye. Past history of a conjunctivitis. Discharge, you can sometimes have discharge with morning crusting, AM, or exposure to drugs. Certain drugs will also cause a red eye. What are your signs? Look for discharge. Usually if you have discharge, it's usually bacterial. Look at your lid and your conjunctiva. Is there edema? Look at your conjunctiva. Is there redness? Always check for your preauricular lymph nodes. Sometimes this is the cause of a viral. And then look for any facial or eyelid vesicles. And so we're going to be talking about the herpes zoster, which is an important cause of red eye. So I just show you the different types of conjunctivitis. As you can nicely see here, you have something called papillae. This is actually, I'm just flipping the lid. You have something here, the follicles. Again, I've flipped the lids. You have a purulent discharge, really important. Again, purulent discharge. This will usually take you more to a bacterial cause. Chemosis. What does chemosis mean? Chemosis is simply accumulation of fluid in the conjunctiva, like you get chemosis in other parts of your body. And this causes, again, redness. And this redness is usually due to accumulation of fluid within the conjunctiva. And then, of course, the redness. This, again, is important. And this is in the palpebral part. So these are the signs of the conjunctivitis that you can see. Bacterial, as we see, what you're seeing here, this is actually just the Q-tip. I'm holding the lid down. The purulent or bacterial conjunctivitis, you have a mucopurulent or purulent discharge. I will tell you this is usually bacterial, and it can occur both in adults and children. They will complain of tearing, foreign body sensation, photophobia. Photophobia means afraid of the light. The photo is light, phobia is fear. So they cannot tolerate the light, burning sensation, or stinging sensation. Usually these are the organisms. Please remember these organisms. This is a common multiple choice question. Usually we'll take a conjunctival swab, as this lady is doing here. And usually we give them, we treat them with topical broad spectrum antibiotics. You don't have to know the names because you're still as a 2nd year. Viral, so now we finished the bacterial, now we come to the viral conjunctivitis. Usually it's an adenoviral infection. It can be acute. You usually have just a watery red eye. There is no purulent discharge. With soreness, you have a foreign body sensation. Again, photophobia, I explained what that is. Your conjunctiva, as you see here, is very hyperemic. And usually you have follicles. You can have follicles, hemorrhages, inflammatory membranes, and this is really the very advanced. You can also have papillae. And this is where it's important to actually go and examine the preauricular nodes. These are the nodes that are around your ear, below and in front. Usually you'll see them swollen. No specific therapy. There's nothing I can do. The patient comes up to me, I just say, "Hey, stay home, make sure you have cold compresses, pump up your immunity, get dressed, and just stay away from other family members and do not touch your eye or touch your family members. And every morning when you wake up, change your pillow." Now, a third type of conjunctivitis is the allergic, like any other allergy you get in the body. This, the most hallmark of allergic conjunctivitis is itching, like any other allergy. These patients will always itch. It's so interesting. They will have, they'll usually have a rhinitis and they'll have asthma. When you ask them, when you take a good history, they'll tell you, "I had asthma as a child," or "I do have asthma now." So you have to remember, the eye is part of your body. So whatever when your body's affected, many times your eye is a reflection of your body. And if the patient doesn't have any asthma history, ask about their family history. This is where a good history kicks in. They'll usually have allergies or atopy. And what are the signs? You get, it's really a mildly red eye, not that red, because of the itching takes over. It's a usually watery discharge, no mucopurulent, chemosis. You'll get a lot of edema, and this is part of the allergy. And then you get a papillary hypertrophy. As you see here, lots of papillae. And then you get giant papillae. These are really giant papillae. To the extent the patient might present you with ptosis, the papillae are so heavy. This is the lid being turned over. The papillae are so heavy that unfortunately it causes a mechanical ptosis. The lids become heavy, and then the patient is unable to open his eye properly. So with allergic conjunctivitis, this is the treatment like you do any other. Cold compressors, you might give antihistamines, non-steroidals. If they have an allergy, give them mast cell stabilizers, topical corticosteroids, and in very severe cases, cyclosporin, but this is in really advanced cases. As you can see, the discharge, it's a watery discharge. They tend to tear. This is the difference between the allergic viral. They have a watery discharge, whereas the bacterial will actually have a mucopurulent discharge, which I showed. What's another cause of a red eye? We have something called a pinguicula, which I'm going to be talking to you about, and a pterygium. So what do we mean by a pinguicula? It's very common. It's non-cancerous. It's just growth of the conjunctiva, as you see here. This is only in the conjunctiva. Thank God it has not reached the cornea. Usually you'll see these in a lot of the laborers, people that are exposed to ultraviolet light and do not wear glasses, do not wear sunglasses. So it's really very important. So this is excessive exposure to ultraviolet light. It will cause a dry eye, and it's usually a lot of exposure to wind and dust. There's a continuous irritation to the conjunctiva. Whereas the pterygium, and I'm going to be showing you a nice picture of it, but before I do that, I'd like just to explain a little. Remember we said yesterday when we talked about your cornea, which is the crystal part you cannot see. When I'm looking at the eye from here, what I see here is, of course, the iris, the colored part, your pupil, your iris, and then this is your sclera. What differentiates the sclera from reaching the cornea? Remember, the sclera is non-clear. That's your white part. Your cornea is the clear. It's actually your limbus. So the limbus, as you can read down here, is the edge of the cornea where it joins the sclera, or the edge of the sclera where it joins the cornea. It's just a demarcation to differentiate the clear part, cornea, from the white part. and it just shows it very nicely here, the limbus. So pterygium is a raised white, yellowish, fleshy lesion, and it's usually at the limbus. And here it is. So it comes here, and then it comes to the limbus, and then in advanced cases, unfortunately, it will traverse the limbus and actually go on the cornea, as you see nicely here. It's actually painful. It's in red if inflamed. And the treatment always, we always encourage wearing sunglasses in the sunlight. And then we do lots of lubrication. We give a lot of lubrication because it really causes dry eyes. This is a routine ophthalmological referral for further management. And I can tell you, we do intervene surgically for this, especially if it changes the contour of the cornea, which is astigmatism, or is continuously inflamed and painful. Foreign body. So foreign body can cause a red eye. What you have to do is you have to remove the foreign body. This is why it's always very important to flip the eyelid. By the way, it's really very easy to flip the eyelid. I had a patient once who came in and I flipped the eyelid and the mother almost fainted. I was explaining to the mother, it is so easy to flip the eyelid. You don't have to worry. I did not know that her brother was in the room with her. Unfortunately, a couple of days later, the mother calls me and says, Doctora, I don't know what to do. My son, who attended with his sister, is flipping all our eyelids when we're sleeping. He's flipping the eyelids of the neighbors, and he's also doing it at school. So it just shows you that it's a really very easy procedure. Not that I'm encouraging this brother to do it, but you should be able to do it when you're examining for a red eye. So you avert the eyelid, you check for more severe ocular trauma, and you rule out penetration of the eye. So, and you also have what we call a corneal. Remember, we said the cornea is crystal clear, you can't see it, but you can see the iris, which is which is the part under the cornea. So technically, if you look here, this is the conjunctiva. You can see it's red, even though it's a red eye, conjunctiva, simply because there is a foreign body on the cornea. And it's really very, so these corneal foreign bodies do cause conjunctivitis. Usually we can treat it with topical antibiotics and treat with topical if the trauma area is small, and refer if unsure. Of course, you do have to refer these patients to an ophthalmologist because I do have to remove this. Again, you have ocular trauma. Again, the ocular trauma can cause a red eye. So beware of signs of a perforation of the eye. The eye can be soft, iris protruding with an irregular pupil, and then chemical injuries also cause ocular trauma where copious irrigation is needed. And I'm going to be teaching you all this hopefully when you come to the fifth grade, and I'm going to be showing you lots about ocular trauma here. I don't know if you can see this, but this opacity here is actually a trauma. This is the lens. It's all clear. This is why you see a nice red reflex. And unfortunately, there is a trauma here to the lens, so it could be penetrating. Now, another very important cause of red eye is your subconjunctival hemorrhage. This, I always say, scares the patient, but always puts us as physicians or ophthalmologists at ease. It's really a benign condition, but because the patient can see it, they really freak out. So when we say subconjunctival hemorrhage as a cause of a red eye, this is under the conjunctiva. You have to remember there's a conjunctiva, episclera, and then the sclera. So it's actually right under the conjunctiva. And if you look at it, as we said, it's blood underneath the conjunctiva. But look at it. If it's interestingly, it always comes into a sector. It always comes into a sector of the eye. Do you see? This is all clear. This is all clear. So this is different from a conjunctivitis. The conjunctivitis is more diffuse. It affects all the blood vessels of the conjunctiva. This is usually in the sector of the eye. And interestingly, as we said, it is a benign condition in most cases, and I'm going to be explaining it to you in a minute. Here, even though this is very diffuse, but you do see areas of white. So this is what we refer to a subconjunctival hemorrhage. This is very extensive. This is involving the whole of the conjunctiva. So usually the etiology could be due to Valsalva maneuvers, which is coughing and straining. Trauma can cause it. Ask the patient if they have hypertension, certain blood disorders, bleeding disorders. Sometimes there is no cause of it. And usually we tell the patient, relax, go home. It will resolve with time. Usually I say 10 to 14 days, but it's usually much shorter than this. Dry eyes, what we refer to as Zika. Again, the dry eyes causes redness. There's usually a burning or foreign body sensation. Tearing is extensive, even though it's a dry eye, but we call it a reflex tearing, and it's usually bilateral, usually affects both. This is just a stain that we're using. You don't have to know about it, but it's a rose bangle stain. And I chose someone with a light iris, a blue iris gray, simply to show the staining. When you see the staining, you do know that the epithelium has already been affected. This is why you get burning or foreign body sensation. Again, what's the etiology? It could be just idiopathic, collagen vascular diseases, conjunctival scarring, infiltration of the lacrimal gland, vitamin A deficiency. And in this part of our world, it's just simply because of the heat and the dust. This usually is the main cause of the dry eyes. How do you treat them? By artificial tears. They can pick up from any pharmacy. It's off the counter medication. And the other interesting thing about it is it's simply tears are artificial. I always tell my patients, just get the minims, the small ones where you use once and throw away, because then you don't have to worry about the preservative. Sometimes the preservative in a medication will also cause a red eye and cause dry eyes. Now I'm going to just spend a minute here, and this is actually the cornea. Remember we talked about the cornea? If you look at your watch, look at the glass, that's clear. This is the clear part of the eye. So I'm just going to be explaining. The cornea has 5 layers: epithelium, the Bowman's layer, which is like a sheet. Then the stroma is the thickest part of your cornea. Then you have your Descemet's membrane, and then you have your endothelium. I just want you right now to concentrate on your epithelium. If I had to tell me one word that describes the epithelium, what would you say? One word, think about it. One word that describes the epithelium. That would be regeneration. The good thing about the epithelium, if the Bowman's layer, stroma, Descemet's, and endothelium have not been affected, any injury to the epithelium is reversible and heals immediately. So it regenerates. So when we talk about a corneal abrasion, the surface of the epithelium that I just showed you actually gets sloughed off. The Bowman's and below does not get affected. It usually stains with fluorescein. Please remember this stain. It's really very important. This is what we call our fluorescein stain. It's usually yellow, but when I'm putting the cobalt blue, I'm actually using the blue light here. It shows up as green. And your corneal abrasion is usually due to any superficial trauma, and the patients are in extreme pain, foreign body sensation, and tearing. Why do you think they have the pain? Why? Remember, even if an eyelash falls into your eye, what do? You blink, you blink, you blink until you get rid of it, right? Simply why? Because your cornea has the highest number of corneal nerves. So anything that falls into your eye is exacerbated with sensation because of the concentration of hundreds and thousands of corneal nerves in your cornea. Again, I'm going to go back to this. Remember, we talked about the epithelium. This is what we call the epithelial defect. What happens if it gets into the stroma? If whatever pathology you have, not only in the epithelium and Bowman, but goes into your stroma, your thickest part. This is what we refer to as a corneal ulcer. So usually with these corneal ulcer, it affects, unfortunately, the stroma. It's usually infection, bacterial. It could be also from the lids. It could be from the adnexial infections, dry eyes, contact lenses. There are so many causes of corneal ulcer. It could be viral, whether herpes simplex virus, herpes zoster, we're going to be talking about that. It could be fungal, and it could also be due to acanthamoeba. It could be mechanical, something hit as trauma, or it could be chemical. Now you have to remember, in chemical we have both alkali and acid. Which do you think is more severe? Of course, the alkali. We're going to be talking a lot about this in your 5th year, but I just wanted to give you a taste of it. And as you can see, this patient has corneal ulcer, and unfortunately here, the chemosis. So, as we mentioned, the mechanical and trauma, chemical, and we said the alkali injuries are worse than the acid. And here just showing, unfortunately, the corneal ulcers and showing the red eye. But more important, once you get the corneal ulcer, it is irreversible because the corneal stroma does not regenerate. But when we talked about the epithelial defect, that does regenerate, and it is irreversible, and your cornea goes back to normal. So I just show some corneal findings. We're going to be talking about this in a short time. So herpes simplex virus dendritis. This is when someone is affected with the herpes simplex. It could be at any age. You get a mild discomfort, you get watering, you get blurring of the vision, you get linear branching, terminal bulbs, corneal sensation, and usually the corneal sensation is decreased, and the treatment is by topical and by removal. So you can see here, this is your herpes simplex viral dendrites. You can see them. It's almost like they're branching. And here's another one here. This is a very common question that we like to ask. So this is exactly how your herpes simplex looks like. We have to treat aggressively. When you see this, please refer immediately to the ophthalmologist, and this is to prevent deeper penetration. You don't have to worry about what you just say topical treatment. I don't expect you to know, but if you'd like to, it's acyclovir. And then sometimes we do have to go and remove the active cells. We do that. You must avoid topical steroids as in any viral infection, because you actually can activate it. The herpes simplex viruses. So these are just different photos showing the different viruses, as you see nicely here. Here's your red eye. Again, the reason I bring this up, we finished now from the conjunctiva and the subconjunctiva. Now I'd like to go into the episclera and the sclera. But I thought before going into that, let me explain to you. Remember, we said the cornea is the clear part, 5 layers. I explained it to you. This is your anterior chamber. This is your pupil, your iris. This is your ciliary body that secretes your aqueous humor, and then your lens, vitreous, and optic nerve, and so forth. Let's concentrate here. Remember, we talked about the limbus. The limbus is the demarcation between the sclera, which is the white part, and between the limbus of the cornea, which is the clear part. That's the limbus. Now, here's your conjunctiva. Remember, we said your conjunctiva, it's actually covering, and then it comes into the lids because your lids will be there. Under your conjunctiva, if you look here, this is the part we're going to be seeing, under your conjunctiva is a layer called your episclera. You can see it here. Under your episclera is another layer called your sclera, okay? Now, under your sclera, and we're going to be teaching you that more in the fifth year, is your choroid. And then under your choroid is the retina. We're going to be explaining that in 5th year. But I wanted you to concentrate on your conjunctiva, which we talked about. Then there's your episclera, and then your sclera. So when we say episcleritis, it's that layer under your conjunctiva. Remember, you don't really see them unless they get the redness. And if you look at your episclera, it's not diffuse. Usually, it's localized, right? It is diffused in the sense, but it's like this part is white, this part. So this is not a conjunctivitis because the conjunctiva usually covers all, but usually with an episcleritis, It can be, it's superficial, but less superficial than the conjunctiva, usually localized, but it can also, as you see here, be very diffuse. How do you differentiate this diffuse episcleritis from a conjunctivitis? If you look closely, these are actually deeper. I don't know. These are actually these are actually deeper, as you can see. Sorry about that. If you can see nicely here, I want to show you a conjunctivitis. I'm just going to go back. Excuse me with that. We're just going to go back to to someone that had a conjunctivitis. And if you can see here, with the person that has the conjunctivitis, see, it's diffuse. The redness is all diffuse, as you can see nicely here. It's diffuse. And more important than that, see, it's diffuse. Whereas when you come to your your episcleritis, look at it. It's really very deep. The other was diffuse and more superficial. Here you can actually see it. It's deeper. So it's superficial, localized, diffuse. It's usually idiopathic. It's really very common with collagen vascular disorders. It's asymptomatic. It's usually mild pain, not that much, and it's self-limiting. Or sometimes we give topical treatment. It usually resolves on its own. Now let's talk about scleritis. Remember, that's now the layer. We said conjunctiva, episclera, and then sclera. Scleritis is inflammation of the sclera, and that's the white part you're actually seeing. This is painful, and it can be, which may be severe, and there's tenderness, tearing, photophobia. This is an emergency. It can be localized, diffuse, or associated with nodules, and it can result in scleral necrosis, as you see here. So when you see someone that has a red eye but is in real pain, this is an emergency and refer to the ophthalmologist. And you can see here, we're already getting necrosis. See, this is the sclera. It's being necrotic. Remember, I told you what sits under the sclera? The choroid. We're going to be talking a lot about that in the 5th year. So what I'm seeing here, this sort of violet, more or less violet color. This is actually the choroid coming because the sclera is being necrosed. It's actually melting away. So you're seeing the choroid, which is purple. And 30 to 60% may have an associated systemic disease. Usually it's associated with a systemic disease. They're usually like collagen vascular diseases, rheumatoid arthritis, ankylosing spondylitis, systemic lupus erythematosus. You're going to be learning all that in your 5th year. Wegener's and PAN. Usually can be associated with herpes zoster and sarcoidosis, and systemic treatment is essential for these patients. And you can see here, unfortunately, there is necrosis here, necrosis here. There is total necrosis. This eye actually had to be removed, unfortunately. So I just show you the different redness here. You can see of scleritis. This is very deep. You can actually see the deep vessels, again showing more of the scleritis, showing more photos. This is when now it has actually necrosed. You can see the choroid. I showed it to you, the sclera, then the choroid retina. This is the choroid showing through because of the necrosis. And this is total necrosis. And you can see these very deep vessels. So I'd like to thank you all for your time. I have tried to make it very easy for you to understand what the red eye is. It can be from being benign to, God forbid, to a scleritis, which many a times, if not treated and referred immediately to the ophthalmologist, we do have to enucleate, remove the eye. So I have now finished the red eye. Please go over whatever needs to be done. Read, there's a lot of things that I did not go from the anatomical point. So please read that. And hopefully, if any questions do arise in the 5th year, we'll be able to answer them. Thank you all very much for your attention.